Hi, it's Terry Kuti of Deep Sea Foundation. We are here to have a conversation to help patients in consultation and care through their decision process for treatment, surgery, recovery, and on to survivorship. If you're a surgeon or a healthcare professional listening, please hit the pause button if you feel you need to and take notes. These are surgeons who have built a footprint of success for you, for your practice, and they care for patients who are affected by breast cancer. I want to acknowledge the ARSA, that's the Advanced Reconstructive Surgery Alliance Network, and leadership for allowing this time and space for me to do these interviews for you, the listener. Please share them with those who you feel might benefit from this information. And I will have contact information at the end of the videos to reach out to the surgeons that I am interviewing, either through IFAR, which is the Institute for Advanced Reconstruction, or in this video, it will be the premier surgical network of surgeons. So with that, let me introduce my guest. I'm speaking with Dr. Yolanda Tammaro, who is a breast surgical oncologist practicing with the Premier Surgical Network. Her office is in Brick, New Jersey. Dr. Tammaro is a board-certified general surgeon distinguished by her fellowship training in breast surgery. She cares for patients facing both benign and malignant breast diseases. She remains at the forefront of innovation, employing cutting-edge techniques such as hidden scar lumpectomies, nipple and skin-sparing mastectomies, and oncoplastic surgery. She utilizes patient-centric approach, collaborating closely with team medical experts to develop the most appropriate treatment plan for her patients. Dr. Tammaro, it is a pleasure to interview you today.
Thank you so much. It's my pleasure to be here.
Absolutely. I mean, I'm really, really pleased to meet you. I would like for you to relate, if we could start out with your personal story. I've heard other surgeons at the summit tell me, you know, their inspiration for starting their work. You have a story to tell.
I do, absolutely. My main inspiration is my mother.
Yes.
I was very young when she was diagnosed with cancer. I was 12. And seeing how hard her doctors worked and fought for her really inspired me to be able to become a surgical oncologist. And my main goal was to make sure that other young girls didn't have to go through life without a mom.
That touches my heart a lot because it was your inspiration. But I always feel, Dr. Tammaro, that caregivers have such an integral part of recovery emotionally and physically for breast cancer patients. So I'm glad that you touched us with that vulnerable moment, because I know it's not easy. When I talk about my boys and my husband and the care they provided for me after my breast cancer and reconstruction, I get the same emotion that wells up. So I appreciate that a lot.
Thank you so much.
Yeah. So when a patient comes to see you for the first consultation, I just remember myself the overwhelming amount of information we have to process. I always say we become unintended students.
Absolutely.
Right?
Absolutely.
So how do you prepare, you know, when you have a newly diagnosed patient, how do you prepare them for a consult to kind of optimize their time with you?
It's really important that if you can, bring someone with you that you trust to the consultation.
I agree.
Because like you said, the first visit is by far the most overwhelming visit because we're not only going to discuss the surgical management of breast cancer, but we're going to discuss other managements as well. And so it's the longest consultation with the most information. It is very easy to go home and forget pretty much everything I've said.
Yeah.
And it's understandable.
Yeah.
So if you can have a trusted family member or friend come with you, that's very important. Sometimes you can't, and that's okay too. And with the technology we have today, FaceTime, speakerphone, we allow that also. So if you have someone that you trust that you can either bring or you can get them on the phone, we're very, very happy. The more the merrier.
Yeah, I always say that second set of ears, second set of eyes, we absorb information through body language at
Absolutely.
a consult. And then if they could just sit and take notes for you. I mean, we certainly don't want people to come and be conversationalists at a consult, so choose wisely. But that is excellent, excellent advice, and I tell other patients that myself in my breast cancer community, so that's good advice. So there's a term that we've heard, or at least I hear at conferences that I go to, and it's de-escalation of treatment. Can you tell us what that term means?
Yes, it's actually very important. So in the breast cancer surgery world, we've kind of come to this realization that sometimes less is more.
Yeah.
We are saving the breast more and more often using breast conservation surgery, which is where we perform surgery which is typically called lumpectomy as opposed to mastectomy. And that's always our main goal, is can we save the breast? Most of the time we can, sometimes we cannot.
Right.
We also de-escalate in other forms of treatment, not just surgery. We can de-escalate radiation. We're providing radiation to not only the whole breast, but now just the site of lumpectomy, where we can do that. We can shorten treatment and accelerate treatment. We're also de-escalating treatment in terms of medical therapy, meaning less chemotherapy for patients with early, good prognosis tumors.
And I think what it's important for patients to know is, you know, the medical profession is not making these decisions randomly. These are all through studies. You know, they look at the benefit of de-escalation through studies, so it's not just a random decision that's being made. Oh, well, let's give them less.
Absolutely.
So, you know, I think about the radical mastectomy that we started with years ago. What was it, Halstead?
Dr. Halstead.
Oh, and how far we've come. So that's good news for patients. I'm glad you defined that term for us, so thank you very much.
And that was an important point. It's long-term data also.
Exactly.
We're talking 20 years plus.
Yes. Thank you for pointing that out. Which, you know, patients don't often look at research and data, but they hear that term often, so they need to know that all of these decisions are based on that. And so long-term data, even better. So thank you for pointing that out.
You're welcome.
You mentioned breast conservation surgery. Let's go into that a little bit more and who might be a candidate.
Sure. Women who have smaller tumors, we can remove the tumor and some normal tissue around the tumor so that we can achieve what's called a negative margin, which just means you don't want cancer at the edge of the lump that you remove.
Right.
So if the tumor is small enough, we can do that. Sometimes, even if the tumor is large, we can still do that.
Yeah.
It's always relative to the size of the breast.
Yes.
And sometimes we can do that with one of the modalities that you mentioned that I do, oncoplastic technique, where we can still save the breast, and maybe just removing that tumor and getting that negative margin alone might not provide an optimal cosmetic result. So we can work together with our plastic surgeons, and we can combine both cancer surgery with plastic surgery. Onco means cancer, and plastics is plastics, oncoplastics. So that's breast conservation.
Yes. Glad you mentioned that. So what would be some of those oncoplastic techniques?
So one technique is to perform a breast reduction at the time of lumpectomy. So women with large pendulous breasts, if they even have a small tumor, they can qualify for a reduction at the time of lumpectomy, which is life-changing sometimes.
Yes. If you have large breasts, yes.
Exactly.
Yeah.
And women who have larger tumors with large breasts will have an optimal cosmetic result with saving their breasts at the same time also. So that's probably our most common form of oncoplastic surgery. If we're doing it without the plastic surgeon, then we can do hidden type scars, where we can hide the scar either in the areola or in the fold underneath the breast. And there's techniques and ways to do that so that you have an optimal and pleasing cosmetic result.
Yes, yes. Oncoplastic. I'm glad you did the combination of the two words, onco and plastic. That was a good description. So, you know, there's a lot to be determined, deciphered, understood when a patient comes in for their first consult. What should patients be asking? I mean, assuming that they're going to do a little homework ahead of time. And I think we have some savvy consumers these days. We have patients that do come in with a lot of questions, but I think there are plenty too, Dr. Tammaro, that don't know what to ask. So if they're listening now, we have an opportunity. What would you say to them they should focus on to learn about at that first consult? Because there's just a lot.
There's so much.
Yeah.
So a lot of times in the treatment of breast cancer, surgery comes first. So if we want to focus on that to understand what are my surgical options, am I a candidate to save my breast? What does that mean? Is there a difference in survival rate if I go with breast conservation versus mastectomy? Understand that so that you don't make your decisions out of fear and you make your decisions based on evidence. Knowledge is power. Talk about your family history. What does that mean? Do I need genetic testing? That's very important because genetic testing prior to surgery can influence the surgical decision you make.
Sure can.
So women with a strong family history and they test positive for a gene mutation might be interested in prophylactic type surgery, like a double mastectomy with reconstruction.
Yes.
Because of that genetic mutation. Women who don't have the genetic mutation, they can go for the breast conservation surgery and feel confident that they're making the right decision.
Right, right. Yeah, and you know, it's interesting to me while you were talking about this, I think about women too in the prophylactic setting. I think sometimes there's a bit of a mental and emotional challenge with them to do a conservation type surgery or to remove both breasts. And I call that sometimes, not to diminish any decisions or anything, but sometimes there's a peace of mind decision that I find there's a component for some patients too. So, all right, so family history, recurrence rate, survival rate, age, all of that goes into that.
Absolutely.
So those are important questions to ask. Now, we started out talking about the initial consult and how much information there is, but then you've done your surgery. They come to consult, you've performed surgery. How do you follow up with patients after surgery? Not only with you, but you have to go back into the OR. So how does your staff support you, you know, and the patients after? Because there's always questions.
There is a lot. And so the breast surgical oncologist is just the leader of a team. There is no way I could do this alone. So my team is incredibly important. One of the most important members of my team is the navigator. So
Nurse
we have,
navigator.
Yes.
Nice.
And we have multiple.
Okay.
And so the nurse navigator works extremely closely with myself and has been working with me for quite some time and has a wealth of knowledge about breast cancer. So their not only important to call when you have a question about surgery, but they provide an emotional support for the patient as well.
Yes.
So when I'm in the operating room and you're spiraling, there's our nurses that can help.
Yeah.
So we have that. There's also the physician assistant. They're incredibly important. They're another go-between for me with a huge wealth of knowledge. Our surgical coordinators have been doing this for a very long time. So they are also an integral part of the team, as well as our medical assistants. So it's really a team effort.
Yes. So to the listener, focus on that word that she said a few times in that conversation.
Navigator.
Team and nurse navigator.
Yes.
You know, you don't think to ask these questions when you go into a consult, but ask, who is the team that's going to be working with me during my diagnosis and surgery? You just heard Dr. Tammaro talk about hers. Again, I want to thank you for this very informative interview this morning, for spending a little time with Deep Sea Foundation and educating the listeners. So again, Dr. Tammaro is with the Premier Surgical Network of Surgeons that is part of the ARSA Summit that we're at this week. And so I will have information to reach out to her and to the Premier Surgical Network of Surgeons for those that are listening. If you're interested, if you're newly diagnosed and are looking for some fine surgeons. So Dr. Tammaro, thank you again so much. It's so lovely to meet you.
You're very welcome. It was my pleasure.
All right, thanks.
Take care.